So, good morning, everyone. I am Dr. Pawan Istapak. I welcome Dr. K.P. Reddy, sir, Dr. Amrish Dharak, Dr. Meenakshi Ravindran, Dr. Rohit Sethi, and Dr. Leonel Raj for this to discuss the modern ophthalmology in this Rethink Advanced Performance. So, Dr. Dharak is here.
Dr. Amrish Dharak. Sir, would you please share your screen?
Good morning.
Good morning, Dr. Rohit.
Good morning, sir.
Good morning. Good morning, sir.
Good morning, sir. Good morning, everyone.
Morning, everyone.
Good morning, everyone. Have a good, productive day.
So, Dr. Dharak is not here.
What about Dr. Meenakshi Ravindran?
I'm here, sir.
Morning, sir. I'm here, sir. Good morning.
Okay.
Dr. Dharak is also there. I can hear him.
Okay. So, the first topic is advanced laser technology for vision correction, including presbyopia. So, I request Dr. Dharak to start his presentation.
Am I audible?
Yes.
Yes.
Sure.
Yeah. Good morning, everyone. So, thanks AIS and thanks Bausch & Lomb for providing this platform to explain and share my experience about this advanced laser procedure, including the presbyopia. Probably with this talk, I would like to focus on this presbyopic correction, since presbyopia is a new dimension opening up in laser surgery. And with, say, experience of around 400 to 450 patients, I can definitely say that I am getting a very encouraging results. Correction laser platform provided available on Bausch & Lomb Teneo. It's basically one-step procedure to correct the refractive error along with the presbyopia. So you can actually, along with hyperopia or presbyopia, you can correct everything. So, Presby LASIK, what you are doing in supracore is you create a multifocal ablation profile which center for near, and you create a hyper area in the aspheric area in the near vision surrounded by the aspheric optimized mid-peripheral zone. So the center works for near and the mid-periphery works for a distance and intermediate vision. So it's a bilateral procedure. The actual procedure creates a 12 micron elevated bump in the central 3 mm zone of cornea, which increases the depth of focus up to 2 diopter in this patient. Whenever you plan to do supracore or any presbyopic correction, the detailed history of the patient, normally in presbyopic treatment, what matters is what you can provide and what your patient expects from you. So with normal history taking along with refraction and visual acuity, normally check for visual dominance also, pupil size also, because pupil, again, it's a pupil dependent procedure. So pupil size less than 2.1 as per the OpScan 3. So probably this case is not very well indicated doing a presbyopic in this plane. General LASIK rules, whatever is required, like say pachymetry, keratoconus, your topography map, any suspect, any abnormality with the cornea, naturally you have to deny those patients for any refractive corrections. Rule out the cataract. Normally, my choice of patient, the age ranges between 45 to 55 is I consider as an ideal age to do this presbyopic correction. Dominance, yes, because when you are talking about extended depth focus, so you don't want to compromise on distance or intermediate vision of the patient. And how it is different from, say, monovision, it provides you a good amount of intermediate vision also, and the distance doesn't get sacrificed to that extent, which normally we practice in providing the monovision with contact lenses. So before you select the patient for this presbyopic correction, the dominance you prefer doing it on your own instead of being dependent upon your assistant. Similarly, so just provide the best corrected vision for the whatever best distance correction is there. Add 0.5 just to make him realize the potential blur he can exploit post-operatively. And the second thing is, and if the patient is comfortable, if the patient is willing to tolerate that amount of blur, then your patient is a good patient for presbyopic correction. The same thing is, again, after for near also, once the patient is okay with your 0.5 blur, then add, if you are doing monolateral treatment, then add 1.5 or add 1.25 bilaterally to get the feel of near vision, what patient will be experiencing post-operatively. If patient is not happy with this simulation, then probably the choice means avoid doing supracore in these kind of patients. Hyperopic patients get very good response with supracore compared to myopes. In my opinion, basically, whenever you choose any patient for presbyopic correction, you have to understand the nomograms provided by the machine, and simultaneously you have to understand what your patient is expecting from you. Instead of my choice of treatment will be not as per the nomograms for the patient. Instead, I would prefer asking the patient, I'll give enough chair time to the patient, I'll understand his needs, and then accordingly, we can slightly modify the nomograms and provide a good post-operative result in this. So my advice to beginners for this supracore treatment, of instead of doing it bilateral, try doing it with mini monovision, means try doing it in non-dominant eye before at least 8-10 patients before you opt for this bilateral. Whenever you are treating, we all understand treating hyperopia, again, the regression is there. Certain amount of flattening usually occurs in 2-3 years. So whenever you are planning a hyperopia and presbyopia treatment, always my plan of treatment is, I normally, if the patient is having say +2 diopter, the best corrected. So normally I tend to correct the hyperopia around 2.5 diopter and then add supracore to it. So considering the flattening occurring in next 2-3 years, you can give rewarding result to the patient post-operatively in those patients. And then the supracore, the actual effect is lasting for more than 5 years for those patients. Same like as a hyperop patient shifted towards more myope patients. In myopia, I would prefer doing the wavefront of that patient, understand the spherical aberrations you will be inducing in those eyes, and preferably then I would like to modify the treatment. My approach towards myopic presbyopia will be a bit cautious, understanding the need, one thing, and second thing, if at all I'm providing say presbyopic correction in myope, I would prefer doing say a simple plano scan, pro scan in the dominant eye, and the non-dominant eye, I would like to do the supracore. So inducing the higher order aberrations post-operatively by doing a pro scan will give you a very good intermediate and distance vision, as well as the near will improve to a certain extent. And micro mono vision kind of concept can be very well induced while treating myopia by these norms. So I would like to discuss the cases in detail about. So this is one case, 36 years male journalist, came for basic correction for distance since he was high hyperop +2.5 and 3.5 and with cylinder, needs glasses for near early onset of presbyopia was there. And then when he realized, yes, this also can get treated. So we tried to experiment the same thing. We explained the patient how far, means we are doubtful because patient was having slight exotropia also. But then we decided to go ahead with the supracore in this patient. So these were the treatment calculations done. And the post-operatively, the uncorrected visual acuity was 6.9 parts and 6.12 respectively. And the patient was both eyes post-operatively, near vision was N6. Individually, if you look at it, then we were able to provide him N8 and N6. A high angle kappa, you always have to keep in mind whenever you are treating hyperop patients. Visual axis centration is the normal thing whenever the kappa reading and everything I focus while doing the suprachoroidal treatment in typically hyperopic patients. There is a second case of 52 years female, and patient was very happy. So probably this LASIK was done with old Bausch + platform. The uncorrected visual acuity after 10 years was 6.6 and patient was accepting near vision of +2 diopter. Again, patient was very much convinced to go for multifocal treatment for presbyopia. This LASIK, I could relift the flap, and by relifting the old flap, we did right eye mild suprachoroidal and left eye regular suprachoroidal in this patient. The beauty of suprachoroidal treatment is the ablation is minimal, so you can provide myopia, presbyopia, hyperopic presbyopia conveniently and comfortably to this patient. Post-operative result in this patient was OD 6.6 and N8, and the non-OS was 6.9 and N6. Patient was happy post-operatively. This is almost 2 years. The patient is doing very well. So proper evaluation and counseling for these patients and explain them the scenario post-operatively helps very well in treating the presbyopic correction. This is the third case, 52 years old male. I'm trying to cover maximum cases where I can show you the variety of patients I treated for presbyopic correction. Like hyperopia, this was the post-LASIK we did. This is the third case. Again, emmetropic surgeon by profession and both eyes plus 1.5. So right eye dominance. In this, we decided to do the mild and a regular on combined basis. So bilateral suprachoroidal was done in this patient. And the post-operative results in that surgeon, this case also were quite rewarding. This is another case of 48 years old female wants vision correction for distance and near. The tailor by profession, and she was having minus cylindrical number. In this case, we did the wavefront and we decided to treat. So in this case, basically what we did was we treated, say, planoscan or proscan in this dominant eye, and the non-dominant eye, we actually treated the regular suprachoroidal. This another fifth case. So as I said earlier, treating myopia, when you come across the map, wavefront map, and if you see you are inducing, say, sufficient amount of spherical aberration post-operatively, so you can actually do a proscan or say planoscan in this patient in dominant eye, and other eye you can opt for mild or regular suprachoroidal treatment depending upon the age and the requirement of the patient. This is another patient, 45 years old, wants distance vision correction, software engineer. Again, addition 1.5, and this was the scene. What it did in this case is we opted for doing suprachoroidal in both eyes bilaterally. So I offered him mild correction in dominant eye and regular correction in non-dominant eye. This is another thing which I have started attempting in last 1 or 2 years. So the basic advantage in these patients sort of treating pseudophakic is patient that way expectations are not great, one thing, and these are mostly 60 plus patients. So even if you are able to provide suprachoroidal at this stage, so patient will have a good amount of intermediate their routine activities without the glasses. The advantage of suprachoroidal is basically being a LASIK procedure, we don't require any extra skill. As a LASIK surgeon, we are well versed with all the tech modalities, and so no additional learning curve is required. LASIK familiar patients are more comfortable with central presbyopia. Minimum corneal ablation, as I already told you, this actually helps, and this is suitable for both myopia, hyperopic, and emmetropic presbyopia.
Dr.
So
Dharak,
being a pupil oriented, it's more of say physiological thing.
Excuse me, Dr. Dharak.
Yeah.
You are exceeding your time. We have one more presentation from Dr. Meenakshi, and only 3 minutes left.
It's done. It's already done. It's already done.
Then stop your screen share. Now I request Dr. Meenakshi Ravindran to present her presentation.
Okay, he asked, good morning. Yeah, now we can.
आता मला 12 मिनिटं म्हणला.
Good morning. Is my screen visible?
Yeah.
Yes, yes, sure.
Good morning all. Thank the AOS organizing committee and Bausch & Lomb for giving me this opportunity. So I will be talking basically on the machine and the our experience. So this is a new Teneo with the bed. If you see, the contour is the natural shape of the spine, and this optimized head position is there because it helps in the patient not able to move his head so much. And it's very comfortable. Actually, I tried once to see whether it is comfortable or not. It is very comfortable. And we have the advanced diagnostic platform with Zyoptics, and we don't have to search for pen drive or floppies and all that. And it's a very seamless flow of data from the workstation to the machine. And this new machine has the touch screen, which is very comfortable. So if you actually put the, like Phaco, if you cover it with a sterile this thing, we can also use the touch screen ourselves. And suppose in case of an emergency, if our assistant is not there to help us. And all the panels are very easily seen, and we can use it. So the whole thing, from the system check to the final treatment screen, even a junior most assistant is there, we can easily guide them. So as we all know that all these lasers, we need the speed and accuracy. So this machine, this spot size is around 1 millimeters and faster, and there is a 2 millimeter spot size also, and so it is very fast. So those who have used the machine before, those who have I have been using Bausch & Lomb from 2004. So I have used the previous machine also. And this Teneo is very fast. Before the blink of the eye, the procedure is over. So around 1 second per diopter it takes. So if you have 5 diopters, within 5 seconds or 6 seconds, the whole procedure is over. So why is it very advantageous is, the main thing is before the patient moves the eye too much, it is over. We can just ask once before starting the laser, we can just tell the patient in another 2 seconds, 3 seconds, it will get over and the whole procedure will be done with. So tracking also is much better because this is the advanced high-speed tracker system is there with a frequency of 1740. Previously it was around 500 Hertz. So it is much more faster. So what is the main advantage with that is it tracks all the X, Y, Z also. And it is a cyclotorsion is also getting tracked. And suppose the tracking goes off, we can use the new, before we have to go back and do here, we have to just click on the present eye movement, and then we can get into the present image, and we can go ahead and do the laser. So that is one advantage compared to the previous machine. And there is less risk of misalignment in when it moves in the Z axis also. So we have the settings of the optical settings. This one thing we have seen is the slightly lower illumination if you use. Patient is also very comfortable, and we also have a very good view. So less dazzling effect rather than the previous model. And the iris recognition is pretty fast. This is very important because it makes sure that we have the correct eye is always operated upon. And so the accuracy and the torsional thing also will get tracked with this iris recognition. So these are the various steps, as we all know, and I have done it myself, and it is pretty simple. You choose and confirm the treatment, and then you center the pupil, and then start the iris recognition, and all the 3 trackings will be on. All the 3 lights are green. A small video to show this thing. So it is pretty simple, no complicated thing. Even we can train our mid-level ophthalmic personnel for this, or we use our instrument department. And here we have used alcohol to remove the epithelium. Once the epithelium is removed, I have gone in for the laser. And as you can see, hardly 3 seconds or 4 seconds is the whole procedure. It is done with. And here we have done a 6 diopters pure spherical with a 40 and 41K, around 6.5. We lifted the flap and femto laser. This was femto flap, and you can see that the whole laser is 6.5. Hardly it takes only 4 seconds for the whole procedure to get over. And this is the post-op picture, where you can see the laser is well centered. So this is another one with a 5.5 with a 1.5 cylinder, a pre and a post, where you have got a very good result. So these are the treatment options available: Xioptics HD, HD Echo, and ProScan. HD treats both the existing ocular aberrations and those that is induced by the laser also. Whereas in echo mode, it's something like the tissue saving mode of the previous model, where it you have some amount of tissue saving and it will correct the existing aberrations that are there in the eye. And ProScan, we have to feed the data. Subjective data has to be fed, like the PRK of PRK this thing, and we have to feed the subjective data. And for some cases, we use this ProScan mode also, especially when the powers are very less, like 0.5. I prefer to do this when it is like 0.5, 0.75, when we are going for selection sometimes, and they're not afford, we go for this PRK mode, or when the risk K values are different, we use this. Supracar has been dealt with. PTK is also available in the system. We have done a few cases. And transepithelial PRK, we are yet to get it, and we'll be getting it shortly. So the epithelial debridement is a single-step procedure by the laser instead of alcohol. And there are this thing. Only thing is it's high speed and single nomogram, so it's much easier. Whereas in the conventional PRK, we can have a toxicity to limbal stem cells and slightly greater post-op pain. But otherwise, at the end of 3 months, if you see, it is almost similar compared to the conventional PRK, the results. So we'll be acquiring it shortly.
Okay, Dr. Meenakshi, Dr. Reddy here.
We have done around 1,000 to 829 eyes since we got it in January 2019, out of which myopic astigmatism was 1,301, and astigmatism plain was 54, and myopia was 474. And all the patients, around 95% of the eyes achieved 20 by 20 uncorrected distance visual acuity, and 100% of the eyes had less than 0.5. So this just shows, this is our experience with this new machine. So that shows that good efficiency and predictability is there. And we have been using this from 2005, actually, caution norm. Thank you, one and all.
Thank you, Dr.
That we have our mentor, Dr. KP Reddy, is with us. I request Dr. KP Reddy sir to express his views on Supracar and TENEO.
No, most of the things are covered, Dr. Sthapak, and TENEO, fortunately, in 2012, I did the prototype research on it. And we have done PRKs, that time Supracar PRKs also, apart from the LASIK. And we seem to have got good results. A quick question to both the speakers. How many PRKs did you do, or have you not done any? Dr. Meenakshi?
Sir, how many?
How many PRKs, Supracar PRKs did you attempt? Any?
No, sir.
No. And Darek, Dr. Darek? Okay. So anyway, I think because of the time, I would request Dr. Sthapak to moderate the next talk, and Rohit and Tarek can join. Can we go to the next talk?
Yeah. Now I request Dr. Lionel Raj to present his paper on versatile laser platform for cataract corneal flap and therapeutics. Dr. Raj.
Good morning, everyone. Am I audible?
Yes,
yes,
sure.
yes. Yeah.
Good morning. Thanks, AOS. Thanks, Chairman, who is a pioneer and who has done several first-in-human trials with this particular system. Thanks to the panelists. Thanks to my first refractive teacher, Dr. Meenakshi. And a warm good morning to everyone. So this is a sponsored session by Bausch & Lomb. I don't have to go much into the introduction, and since ocular damage subsequent to exposure of sunlight, solar eclipse, there was an idea of using therapeutic lasers in eyes. And femtosecond is the latest iteration, which falls into the deep infrared zone of between 1028 and 1053 with 10 power minus 15 seconds as the frequency. The final effect is it's a high precision knife which can create incisions, it can create planes, and it can also produce pouches. And it's been available into systems for use since 2001 and very commonly being used in LASIK flap creation and in SMILE. And it has been suggested that the edges of femto-assisted keratoplasty are very clean and wound healing is very fast. Faster suture removal is also possible. So all these are, this is the team which developed, and femtosecond laser applications presently, they are not alone in the cataract surgery, also in several forms of corneal therapeutics like intrastromal rings, presbyopia correction as in refractive surgery, and several forms of keratoplasties. And that's why we can call this as a versatile platform for a person who is a subspecialist in cataract, cornea, and refractive. So I'm discussing about a system which is Victus, a product of Bausch & Lomb, but I have no financial interest. So Victus is a universal platform, as I said, which can work both for a LASIK, corneal therapeutics, and cataract. The newer thing is it has incorporated switch source OCT, which is designed for higher contrast. The experience is 62.5 times faster video frame rate, advanced identification management system, real-time OCT, planning for corneal procedures. So the objective of my talk is to analyze the efficiency and reproducibility of femtosecond lasers in various aspects of cataracts, corneal flaps, and therapeutic procedures using single platform. It's a retrospective analysis of 1,691 femto-assisted ophthalmic procedures in our center, and in addition to 5 pooled analysis of 5 investigator-initiated prospective trials. Out of the 1,691 procedures which were performed, 44% were for LASIK flaps, 735, and 701, that is 41% is cataract. More interesting is for a cornea person like me, 15% indication in therapeutics. So Victus in cataract surgery. 2 different docking systems are available. One, if a fluid is present between the patient eye and the interface, then we call it as a soft docking, like this. Then we have, so this is a soft docking procedure, which is effective in visualization of the lens, crystalline lens. Whereas a regular docking is a one which is used for visualization of the corneal structure. And here we don't have fluid in between patient's eye and the interface. So I've just run with one of the videos. So here we can see, we can plan for capsulotomy, we can plan for lens fragmentation and the incisions. And again, the lens fragmentation, we can make circular cuts, we can make radial cuts, we can make combinations, and we can have grid. The pupil gets auto-registered when it fails, we can always go for manual marking of the pupil, what I did in this particular area. And similarly, we could mark the anterior and the posterior lens surfaces. We can mark the capsulotomy, we can reduce the size of capsulotomy, we can, in addition to automatic works, we can always modify according to the needs. The first one to go is the capsulorhexis, followed by nuclear fragmentation, and finally, with the regular docking, we proceed with the incisions. A triplanar incision is being fashioned, a primary incision, maybe 1 or 2 side port incisions as well. So this is the end result. We also saw some of the shortcomings in femtocataract. Out of 741 cases, 718 cases, 7 we had less than 1%. We had oversizing of pupil when automatic registration was happening. So we presume that it is because of some artifact which is sensed as pupil, and we also recommend in such cases to avoid to make a manual marking and to proceed. This is one case wherein we left marking it manually, and we had lasers on the pupil surface, but that was very less. Yeah, and femtosecond laser in refractive surgery, widely used in SMILE and femtoLASIK, as we all know. So this is a case of femtoLASIK, where a clean bed is being created first, followed by the rim. We can have the hinge anywhere, and I prefer to have it on the superior aspect. And the ease of opening of the femto-LASIK flap is also being shown in this particular video. Yeah, it opens easily. There you go. We had 2 complications till date, both in the first 10 cases. The first one, within 5 cases, we had some problem with the system, and a part was replaced where we had a asynchrony between the bed and the ring. That was the first one. Second one, we had a section loss, and in between, and I had to take up for manual microkeratoma assisted flap, and I could complete the procedure. And presently, the system is also incorporated with only making a rim cut that is possible now. So all these can also be managed using femto system only. So femto laser in corneal surgery for a corneal person like me, that is more interesting than cataract and LASIK. So we write this way: corneal therapeutics could be redefined using femto-assisted corneal procedures. So out of 255 procedures, major indication for us was in deeper stromal cross-linking, 89, then lamellar keratoplasty, then stromal addition procedure, PK, and also we did several endothelial keratoplasties. So this is one of our case series, a prospective study, where we made a pouch with 1 or 2 incisions, anterior stromal pouch, 160 or 140 microns deep, and infused riboflavin dye into the pouch for deeper absorption into the deeper structures of cornea, and subsequently UV irradiance for deeper cross-linking procedure. So in 2 phases we analyzed. Phase 1 we compared with conventional procedures. Phase 2 we followed the single arm femto-CXL subjects for 3 years, and we found deeper stiffening, reduced keratolysis, and it is non-inferior or superior to conventional procedures. And interestingly, the depth of demarcation line in femto-assisted cross-linking was 394, the posterior cornea as well. when compared to conventional procedures, and comparing to historical samples, this is the deepest value which we could find, and no endothelial changes were seen. And the single arm longitudinal analysis over 3 years, we found vision to be stable, minimal pachymetry to be stable, astigmatisms to be stable, and femto-treated eyes remained stable after 3 years. We had haze in the center, which regressed over a period of 3 months and no more seen after 1 year. And regarding lamellar keratoplasty, this is a case of corneal stromal dystrophy, granular dystrophy, involving the anterior and the mid corneal stroma, where I took the patient for a deep dissection of lamellar keratoplasty. We can always alter, and we can go up to 90% depth of the desired level of the cornea. And yeah, a deep dissection. This can prevent air bubble associated or a big bubble technique or Archilas technique where we could perforate. So perforation could be avoided, and it's more precise, more reproducible. Similarly, I also make dissection of the donor corneal stroma, donor cornea, and finally we take the patient to the OR and exchange the lenticles. So easily it comes. And just change the lenticle. So this is another case, an extremely thin cornea of advanced keratoconus. Again, a deep dissection is possible, and a DALC is very much easily possible in this particular case. So any thin cornea, we can do a precise dissection using femtosecond lasers. This is another case wherein we had an infiltration in the center involving the anterior and the mid stroma. I wanted to go posterior to the infiltration and remove the corneal infiltration and replace for a therapeutic deep anterior lamellar keratoplasty using femto lasers. In cases of penetrating keratoplasties, the rims are very clean. Like in this particular case, a central scar involving up to Descemet's in the endothelium. Femtosecond laser helps in clean dissection, unlike manual traphenes. And similarly, donor tissue is also dissected using femtosecond lasers. And finally, the corneal buttons are exchanged. Such a clean dissected ring, and there you go, a clean surgery by the end. So femto laser helps in penetrating keratoplasty as well. And incision for intracorneal ring segments, as we know, femtosecond laser creates channels and incisions for intracorneal ring segments, and it helps in easier implantation of ring segments into the cornea. Corneal stromal augmentation, this is something which we did some form of innovation, wherein what we did is we took a donor lenticule of nearly 150 to 250 microns, depending on the requirement. And also we created bed and incisions in the recipient and just did an intralamellar transplantation. Since all the dissections are done using femtosecond lasers, the interface appears to be very clean and healthy. So this is our case series where we compared with the deep anterior lamellar keratoplasty, and we tried to prove that this is non-inferior. And in addition, there are no suture-related adverse events and early ambulation of vision. And addition of tight layer of cornea corneal tissue into the cornea flatten the posterior cornea much more than that of the anterior cornea. And superior to inferior asymmetry as a measure of irregular astigmatism also reversed in our series. Endothelial keratoplasty, we also used femtosecond lasers in the field of endothelial keratoplasty in order to make an ultra thin or a micro thin posterior corneal graft. I use femtosecond lasers to dissect. Here it is real-time OCT guided dissection. So it is unlike running with keratome. It's OCT guided real-time dissection. It's well seen, and I prefer to have a posterior corneal graft thickness of around 65 to 70 microns, and rest of the procedure just goes like this. So this and 19 eyes of 18 subjects we studied, and our thickness, graft thickness was it is 67 microns in V. We had no hyperopic shift, and the interface properties were very excellent. Very excellent. Yes,
Lionel, the time is up, Lionel.
Yes, and as we know, we also used for several other indications like implantation of drugs and other things. To conclude, femtosecond lasers has taken cataracts to high level of refractive surgeries, and it also created LASIK flaps with ease and maximal precision. It has redefined corneal therapeutics of lamellar keratoplasty, ring segments, collagen cross-linking, therapeutic management of corneal ulcers with excellent outcomes. However, these are robotic surgeries, and we need caution and skill. Thank you, Anand, for patience.
Thank you. Thank you, Lionel. I think we have next a video, a pre-recorded video by Dr. Nuno Campos on Advanced Corneal Explorer. Can you please run the video, please?
As you know, I've been diving for 30 years, more or less, and ophthalmologist for 20 years. For me, safety is the main reason to do everything in my life. And with the ACE, I will dive safe with the ACE. When we dive or when we perform surgery, there's always some news. And we have to be very assured that everything is okay. With ACE, we have the comprehensive data, images, and everything that we need to perform a surgery with all the main reasons to be assured that there will be no problem. And ACE in this moment is my main stable for refractive and cataract surgery and also for corneal surgery. With ACE, we have breakthrough technology. We have OCT swept source, short acquisition times, eye tracking. We have everything that we need to perform a good examination of the patient and also to be assured in the operation theater. We have beautiful images. With this swept source technology, we have the most beautiful images of the anterior chamber of the eye. And in my professional life, it's the first time that I see a comprehensive capacity of having all the anterior chamber of the eye in very, very good views. This swept source technology, we have all the data here, but the main reason to use this device is that in clinical practice, everything that we need, it's on the display, and this is very assuring for the surgeon. We're gonna talk today of the corneal HAP. As you know, ACE is the several apps, but the one that is more important to me as a refractive surgeon is the corneal HAP. In the corneal HAP, we have topography, we have tomography, we have pachymetry, we have wavefront analysis, differential maps, and in case of keratoconus disease, we have a progression analysis also. We have the option of varial and several displays. The ones that we use the most are the single view, the multi-view, comparison of both eyes, and the follow-up layout. The multi-view displays all the data that we need in the cornea. We have the anterior and posterior curvature. We have the anterior and posterior elevation. We have the pachymetry, total corneal power, wavefront analysis, and also the most beautiful images in the OCT images. Here we have some displays of a healthy eye with all the corneal power of the anterior surface. Here we have the total corneal power of all the cornea in a healthy eye also. And we have the pachymetry view also. We have the wavefront analysis, and we have also the capacity of having a multi-view map that in the strategy of preparing the surgery, it's the most important thing. In keratoconus, as you know, it's a disease that is progressing a lot in Europe. We have the thinning of the cornea that it's most visible in the OCT images. And this is very important in the first steps of the disease. Here we have a map of the keratoconus in a patient with a disease that is in stage 2. Here we have the keratoconus in a patient with both eyes with keratoconus. Here we have the multi-view. We have also several types of multi-view maps that we can have, and they are very important to have a comprehensive situation, a comprehensive analysis of the situation. Here we have another option for a multi-view in keratoconus. Here we have another multi-view, and these maps are very, very important to have the best surgical strategy regarding which one of the patients. When I have to decide if I will perform corneal rings or no, the ACE is my main stable for having the best decisions in my daily practice. Here we have the progression analysis. When I have a new patient with keratoconus, I have the ability to have along sometimes a period of 2-3 months, and I can have this app with progression analysis. And with this progression analysis, I can have the best decisions in the best time also. But in surgery and as in diving, connection is the key. So we have the cherry on the top of the cake. And the cherry on the top of the cake in this moment is the connection between the ACE and the Teneo. With this connection, I can have always in the operation theater all the data, all the information that we need to get the best decisions in the best time.
Okay, that's a lovely video on the ACE. I think we'll move to the next talk. I would request Dr. Chowdhury and Rishi to please moderate this session, this talk.
Excuse me, sir. The panelist chairman, sir. I have another session also. Would you mind?
Okay. Okay, Lionel, please. Thank you very much for participating. So kind of you.
Hello, everyone.
Hi, Rishi.
Hi, Rishi.
Good morning, sir. Good morning, sir.
This is Dr. Bhaskar.
Hi, Kamal.
So let's move on. Let's move on to the next part of the program, and we'll invite none other than our immediate past president of AIOS, Dr. Mahipal Sachdev, and he will talk to us about predictable astigmatism correction, role of IOL design and material.
Thank you very much, Rishi. Pleasure seeing you and Dr. KP after a long time. And Kamal.
Namaskar, sir.
Namaskar. Hope all of you are doing well. And thank you very much.
Congratulations on a fabulous tenure.
Thanks, Rishi. lot of load off my head, feeling relieved. Anyway, tumultuous time. Anyway, I'll be talking about toric IOL. I wish to thank AIOC and Bausch & Lomb for giving this opportunity. So as you all know that today the target of emetropia is something that the patient desires, and all of us are looking at reaching this particular target. And toric intraocular lenses are something that is gaining in everybody's practice. So I'll run you through what the toric process is as regards clinicians, and then we'll talk a little bit on the design, the material, the optic haptic junction, etc. So what are the additional steps that one requires when one is looking at implanting a toric intraocular lens? And these would be the preoperative, intraoperative, or even looking at the postoperative. Now, there is a possibility of the potential sources of error which could get compounded. The first error is a proper biometry, and I'll be talking about the anterior and the posterior corneal astigmatism. Then you had to normally write it down. There's a transcription error, then planning error could be there. Then the marking, if you are doing the physical marking, there could be an error there. And then when a patient is lying down and when a patient is sitting up, there could be a torsional error. Then there is a surgically induced error as to how much you are feeding in for your surgeon or your different person surgery. Capsular axis being imperfect and the lens getting decentered. And finally, the positioning, which is on the table as also post-operatively, and how are you optimizing your outcomes for all these particular things. So when we are talking about the first part, that is the pre-operative examination, that is to measure the keratometry, which is very, very important, as also the biometry, which is very important. Now, one important thing that I'll wish to say is that the IOL power calculation should be done on an untouched cornea. If you are working on a cornea that has been invaded with, say, xylocaine, paracaine drops, or a tonometry has been done, or an A scan has been done and you have touched, then the readings would not be good. The surface of the cornea needs to be optimized if we are looking at ocular surface disease, and then only we should look at doing the keratometry as to what is the correct thing. The next important thing that comes is a toric calculator, and this is important as to how accurately the data is being inputted. And the lens is normally recommended by the calculators, which each company has for their intraocular lenses, but you can also use a Barrett toric calculator if you want. Now, the third thing then comes is the marking. Majority of the ophthalmologists still do not have access to the markerless systems, whether it be the Callisto, whether it be the Varion, etc. So there is the dexterity that is required in doing a proper marking, and there are several techniques that needs to be looked at, and the person should be adept at doing a proper marking with the 0-180 degrees. Then comes the question of the intraoperative alignment and how are you going to place with the marked axis. So you can mark it on the table also, and the placement of the lens has to be there. And if there is a misalignment of the IOL, we'll be talking about it, that can cause a problem. And the final marking should be after the viscoelastic has been taken out and there is a nudge, maybe slightly clockwise, that is there for the final alignment. And then 1 day, 1 week, 2 months, or 1 month later, you have to do the post-op alignment check. There are several systems now. The femtolaser systems are getting you the marks, which can be seen later on. There is the steep axis alignment, which has come into the femtolaser systems, and the topography from, say, the Cassini will be passed on, and it will talk to the machine, and then you can have the alignment marks on the cornea, and you could align the toric marker, and then these marks can be seen later. There is also a smart thing of a round notch in the capsular axis, which will be remaining there, and you can look at that particular thing as regards the post-op measurements of the placement of the toric IOL. Now, I would say the IOL Master, which is the 700, is among the best things, but if you don't have, you can do an immersion, A scan, and as I told you, a keratometry that is required. Autokeratometer and IOL Master, autotopographer, all of them can be used, but the problem is, what are you wanting to measure? So it's the central ring, which at times is the best, which you want to take the central corneal keratometry, and this is better to measure the center of the cornea, and you can take it on 2-3 particular equipments. At times, a topographer, the axis difference is different from what a keratometer. A manual keratometer is really the best. An autokeratometer could give you, an IOL master could give you, and a topographer could give you different readings, and then you have to really decide which one to go in for. Now, when you are looking at the toric planning, there are 3 major issues. The first is what is called as the posterior corneal astigmatism, which I'll dwell in a little bit. Then the second is the surgically induced astigmatism of the surgeon, and third is what is known as a toricity ratio. Now, posterior corneal astigmatism, the first thing let us consider, a posterior cornea is steeper vertically, which translates to power horizontally. And that is at an average 0.5 diopters against the rule when the interior cornea has with the rule, and 0.3 diopters against the rule when the interior cornea has against the rule. That means that the posterior corneal astigmatism could be different or would be different from the interior corneal astigmatism, and it could be different as regards the difference between with the rule or against the rule that is there. Now, the anterior corneal astigmatism, there is a gradual shift with to the against against astigmatism. Against the rule astigmatism from with the rule as a person ages, and this is about 3/8 of a diopter over a decade. However, the posterior corneal astigmatism remains unchanged, that is there. So posterior corneal astigmatism, there are several ways whenever you have a pentagram or a Galili, etc. And now they are trying to combine it with the OCT, but the simplest is to get the total keratometry reading on the IOL Master 700. That is something where you get, so you can see that if you are looking at this particular number, which is the TK, this is the anterior minus the posterior. You can also, on the Barrett's formula, have a proposed or a postulated TK, which can be done and which you should look for in cases of doing a toric intraocular lens, and the TK will be different from the astigmatism that is being measured in your particular case, which is there. So you can see here that if you look at the diopters here, 45.83, 46, and this is coming as 0.57. This is a combination of anterior and posterior. Now then let us go on to the toric calculator. So you can go on to their websites. Each company, as I told you, has separate toric calculators, and you have to feed in the entire range. And then you can rotate and you can say as to which is the lens, the axis, the power that you wish to do. Where is the, you can say calculation. This is the pre-op corneal astigmatism. This is the surgically induced astigmatism. This is the expected post-op corneal astigmatism basis where you are putting the incision, then IOL power cylinder and the residual astigmatism that you are getting. So you will get a printout of the power that needs to be implanted into the eye, and this is the product name and the power, etc. that you get, and you will order that particular lens which is there. And you have this summary as to where the lens has to be placed, where the incision has to be placed, and what is the steep axis. This is what you get in the cases. Now, one important thing for you is that 0, 180, sometimes people get confused. So this is the diagram which is 0, that is 0 and this, and 180 on this. So when you are sitting on the right eye, you have the temporal, this is temporal on this side, 0 on the left and 180 on the right. So this is how you have the 0 to 180 which is there. Now, the marking of the intraocular lens for on the cornea, in average, the IOL placement error is about 4.9 degrees, and it can go as high as 15 degrees. This is the average that you are getting because of the manual marking and the placement. So there is 2 steps. First is the pre-operative reference marking, and the second is the axis marking, which is the intraoperative step that you have. So the markings can be done using the bubble level, the gravity. It can be done with the slit lamp, blood vessel scanning. But if you are doing the IOL master with the Callisto, it will talk to each other, and the cyclotorsion, etc. can be there, and you don't really need to mark anything. These are various methodologies. Freehand marking, the patient has to sit straight on the slit lamp. This is the bubble marker that you have. This is the slit lamp marker that you have. So these are the ways that you want, and this needs to be very precise as regards the marking. Sometimes if you are marking, see, if you can see here, If this mark is here, that is fine. But if the hand goes down and the marking comes here, then it becomes a little problem, even though it is aligned 0-180, that is in this particular thing. These are sophisticated equipments, which is the Aura, which very few of us has, because there is a click fee. So you go here, and once you are having the eye, after the cataract has been removed, and after the lens is placed, you can, the Aura can tell you whether there is any rotation that is required or not, and you can get good outcomes with this particular thing. Now, once you have marked 0-180, in the intraoperative axis marker, you have to really tell where you have to put the lens, and that is what you mark on the table. The most important thing is that you need to dry up the cornea, and you need a pen which will not give you a very large mark. Now, the IOL needs to be therefore properly aligned to the axis mark, and there are 3 steps of intraoperative alignment: gross alignment, then you remove the viscoelastic with YA, and the final measurements that is there. This is just to show you a femto procedure that has been done. And you can see here, this is the incision. It is slightly different from the mark. And then you can see that this is the Callisto system, that after you have implanted the lens, you will actually need to see as to the alignment on the mark which is there. I'm just taking this forward. So this is the Callisto. This is the markerless system, the IOL 700 that is used. You put hydro. You don't want the chamber to become shallow, because there can be a tilt, and then you can mark the alignment that is there. Now, the post-operatively, the patient is showing you not a good 6-6 vision, and if on the auto-ref you are getting a plus and a minus, that means that there has been a rotation. So the best thing is to dilate the patients on the post-operative day, and to redial them if you feel that there is a difference. In a femto, if you have a mark here on the cornea, you can see whether this mark and this mark on the cornea is aligning or not. Otherwise, you will have to get the picture and see whether there has been a movement or not. Ideal is to do the realignment as early as possible. Now, let us see as to what the Envista Toric platform offers us, which is one of the lenses that I have of choice, the IOL material, the haptic, and the optic design. Now, the hydrophobic acrylic material that is there gives you better bioadhesion between the IOL and the capsule, leading to minimal lens epithelial migration. The spring force of the haptics which is there is greater and does not degrade over the time, leading to good post-operative stability. And this is afforded the greater elasticity and the stiffer optic-haptic junction, and the optic haptic is there. PCO is almost negligible in these particular cases. The lens glistening is not there. The Envista material is really great. It resists scratching also, and results in a stable IOL that remains largely unchanged by the intraocular lens. Now, the modified C-loop has fenestrated haptics, which is again a good thing which you don't see in single-piece lenses, and it minimizes transmission of forces to the optic, and the optic maintains high quality, and there is more contact between haptics and the capsular bag. The step-vaulted haptics are the other things which help reduce the PCO. So this is the hole that you see where there will be an attachment between the anterior and the posterior capsule. So it keeps it in place, as also this offset of the haptics to the, this is the offset that you have. So this pushes the lens down, and this, the sharp edge helps you the PCO. In a 2-year observational study of 106 eyes that have been reported, no patient underwent JAK capsulotomy, and the Envista Toric is designed to resist growth of lens epithelial cells into the optic and limit PCO formation. So this is what I am saying. The other thing is the large contact area that you have, and these fenestrated holes, these are very, very important. And the interior offset of the haptic, as I told you, pushing the lens down, keeps the lens very, very stable, and exceptional rotational stability has been shown. So this is the precise rotation, which I'm saying is important. One day you can see, 1 week and 1 month it is there. A 10-degree off axis reduces the correction by 33%, 30% off axis, there will be no correction. And if you are 90% off axis, you will be causing harm to the patient, and you will be doubling the astigmatism of that particular patient. In US FDA trials, 92% of the eyes for Envista Toric had less than or equal to 5 degrees of radiation at 4 to 6 months later. So Envista, to sum up, is a lens that is a lens of choice for me for the toric implantation. It is an abrasion-free optic. uniform power from center to edge. So even if there is some decentration, the problem is really not getting compounded in any way, and it gives you an increased depth of focus. You can see here zero abrasion lens, possibly at times better than a negative spherical abrasion correcting lens. So to sum up, toric IOLs are a reliable tool to correct pre-existing astigmatism. They are better than corneal-based LRIs procedures. Cataract surgeons should adopt to toric IOLs in their practice to enhance patient outcomes. We are underdoing the number of torics that is required. We should look at the doing torics in anything, I would say, above 0.75 to 1 diopter, I would say. The only thing is that the company needs to possibly have a lower price for lower astigmatism that is there. Meticulous pre and intraoperative planning is required, and improved imaging modalities are the future. So thank you very much for your kind attention. Thank you.
Thank you very much. I think
go on,
should we go straight to Kamal, please?
Yes. So the next speaker is Dr. Kamal Kapoor. He needs no introduction. He's brilliant surgeons from North India, from the Sharpside Group of Eye Hospitals. And he will be talking to us about the next gen surgical system, chamber stability management, and innovative cutting technologies.
Okay, so before I start, I think it's an honor to be sharing the podium with Dr. Reddy. And
thank you, Kamal.
Huge respect for him. And Dr. Mahipal, of course, a dear friend, Rishi. And I think I must thank Bausch + Lomb and AIOC for creating this platform for, sharing information, knowledge. And the best part is, in spite of bad COVID times, the spirit of academics and sharing is still going on, and that's so encouraging. So I'll be sharing this presentation on Stellaris Elite Vision Enhancement System. As most of people know, I'm a big, huge Venturi fan, and I'm a diehard Venturi fan. And I just love the fluidics of the machine. So I'll be speaking from my personal experience, and I will also be touching some very, very basic points of an enhancing understanding of why a Venturi system would probably outdo a peristaltic system, even a very high-end peristaltic system. But here we are talking about Stellaris Elite. And I am a technical guy with my hands-on physics, so I will try and explain with physics examples. I have no financial interest in any of the machines I'll be talking about. There are 3 models available: the Stellaris Elite Anterior, the Stellaris Elite PC, and the Stellaris Elite PC with a laser machine. Now, what is new in this machine? I actually feel, Stellaris actually, in my mind personal, was a gold standard when it came to fluidics. Most of the other machines in the market were, having all the bells and whistles of, the fluidics, the, surge controls and new pumps coming in and new softwares. But the basic of understanding a Venturi system, how it behaves, Venturi is always a real-time vacuum on your tip. Let's understand, when we use a peristaltic machine, there are rollers which are moving, and the vacuum is transmitted across the tubing, and then the tip has to be occluded. And the amount of occlusion of the tip decides what is the vacuum you get on the tip. So you could have a 300 vacuum in the machine, but if your tip is 50% occluded, you would have 50% of 300, but not the same with Venturi. If your foot is at 50% of 300, you get 150. If your foot is full at 300, at the tip, you get 300. So that makes it very predictable. Now, add on to that, the adaptive fluidics, this new dynamic fluid compensation system, which has got a controlled pressure, maintaining an infusion and outflow mechanism, which is being monitored. Now, what it does is, we will see as we move on, this is called adaptive fluidics. So coupled with a beautiful pump system of a Venturi machine, we have a system which is now linearly controlling your infusion pressure in the eye, which means most of the machines where they are gravity fed or pressure fed, if you stop the fluid, let's say a surgeon is operating under a continuous flow, what happens? There's no outflow. And if you have a tight wound, and even if you have a leaky wound, the pressure goes up. And the moment you go on to vacuum, the fluid flow rate starts. Let's talk about a flow-based system or a peristaltic system. The fluid starts coming out, and that's when the pressure starts coming down. Now, what happens is in pressure-based systems, in the other peristaltic machines, the response time is based on how the pump starts and how the compression of the fluid bag happens. Unlike this, in a Venturi machine, you have, the moment your vacuum keeps going up, linearly, the pressure in the bottle keeps going up. So it maintains a constant infusion pressure in the machine, which is real time. And coupled with the aspiration of a Venturi machine, the vacuum at the tip is vacuum in the machine. So you can actually tailor make the fluidics and the balancing of the infusion pressure very, very accurately. So it's a real time actual monitoring of the fluids. What else does this new machine have? In the interior segment, you can have a cut rate of 5,000 to 7,500. And especially the basic machine, the cut rate has gone down to 2,500, gone up to 2,500. You have an active reflux. And I said, I will be talking about adaptive fluidics if my time permits. You have a dual cutter for the other, my colleagues in Vitreoretina. Now, how does this do that? It monitors your flow rate, vacuum flow rate in the machine. There are sensors. And the moment the vacuum flow rate increases, the vacuum increases, the machine automatically pumps more air into the bottle and compensates for the increase in vacuum. Now, let us understand the basic, very basic fluidics, and then I'll build on it. The flow is how fast a cataract piece is sucked towards the phaco tip. A vacuum is how hard it is held once it is coming there. And of course, the phaco power is how much of cutting force the thing has, or the phaco tip has. I'll be discussing all these threadbare. Now, this is what an aspiration flow rate does. A peristaltic machine, when it tries to behave like a Venturi machine, has to go on a very high flow rate. But what happens? The moment you go near a piece, it's sucked in, and then the occlusion goes, and you lose the occlusion. And when you lose the occlusion, the vacuum drops again. And then again, you need to look for an occlusion to build the vacuum again. So if a surgeon really wants to operate hard, he needs to increase the flow rate. But then there are the other collateral issues which go with the increased flow rate. Now, what happens? What does a vacuum do? Now, in case you have a Venturi system, the vacuum is always there at the tip. So if your foot is in phase 2, the vacuum is already there, whether it's occluded with a phaco fragment or not. Unlike a peristaltic system, if you lose the fragment, the vacuum is lost. Then you again need to go and occlude your phaco tip. Now, the basic difference is,
Dr. Kamal, are you there? Okay, while we wait for him, are there any discussions we'd like to do from the previous talk? Okay, are you back, Dr. Kamal? All okay?
A gentle reminder, sir, there is a 12 minutes to conclude the session.
I thought we have time until 12:55.
Yes, sir, that is 12 minutes from now.
Yeah, 12 minutes. That's fine.
Yeah.
Dr. KP Reddy, any comments so far? While we wait for Dr. Kamal.
You have to unmute yourself.
We can't hear you.
Dr. Reddy has to unmute himself.
Yeah.
Yes.
I think I lost the internet. Can you hear me now, sir?
Dr. Kamal, are you okay now?
Yeah, I lost my internet.
Okay, Kamal.
Okay. Please continue.
Yeah, this is the basic difference. I'm sure all surgeons know that, but I just want to highlight a few points. In peristaltic, the vacuum only will be created when the phaco tip is occluded. So what does that do for the surgeon? You need to hunt for a phaco tip to come towards you. But in case you don't want to hunt for the piece, you need to increase the flow rate. When you increase the flow rate, the piece is sucked in faster, or the flow rate probably starts pulling things faster towards your phaco tip. Whereas this is not required in a Venturi system. We will extrapolate this in an elite system. Now, this vacuum is always dependent on how much amount of percentage the phaco tip is occluded in a peristaltic system. Whereas in a Venturi system, it is totally independent of how much of tip is occluded. Now, what does this do on the real world? In case you lost your vacuum for a fraction of a second, you need to take your foot off. So during that time, you have lost some energy. So there is again a lost escaped energy. Whereas in a Venturi system with a good flow, there is energy is always absorbed and the piece is always there at the tip. Now in adaptive fluidics, what happens is the moment we will see this graph, the moment you go on to vacuum, the pressure in the bottle goes up like here and increases the pressure inside the eye. Now, unlike a normal situation, which is probably with the earlier Stellaris machine, what we were doing was if the pressure was actually going, if the vacuum was going up, the pressure would go down drastically. But in adaptive fluidics, it maintains the constant pressure. So the surgeon can actually decide what is the infusion pressure in the bottle he wants, and he can have a constant pressure irrespective of the bottle height and the vacuum setting he's at. So this would give a predictive advantage in glaucoma patients. Now let us understand about the marriage of a good tip with a 28.5 kilohertz handpiece. This is how a cataract would be cut, and you see that it is the flat edges of the phaco tip which actually cause cavitation bubbles and cause the breaking of cataract. Now what does a Venturi machine, which is working at 28.5 hertz, help us? Now let us see all the phaco tips we have. There is a comparative study. The actual cutting is done by the mass face of the edge of the phaco tip. And what we have in Stellaris is we have the famous Dr. Barrett's microflow needle. Now this has got a very thick flat face. So the raw energy which is being delivered for cavitronics is very high. And there are side grooves which work here, which help to cool the wound and cool the tip. So this comes to advantage because you're working at a 28.5 kilohertz tip, which actually has a very long stroke length. Most of the machines we work are working at 85 mils to 100 mils. This is the only machine in the market which is going up to 140 mils. Now what it means is longer the stroke length, better the cutting. But yes, it generates more heat and cause wound burn. This is where the microflow tip comes to our advantage. In microflow tip, there is more mass at the edge. There is a diaphragmatic cut section, and there are cooling areas in the side. So you can marry this needle to a 28.5 needle and get the best possible thing. I will jump this, sir. I think this is a bit, yeah, this is interesting. Now, when you do a comparative of adaptive fluidics, it has been proven that it is far more faster response time in maintaining the intraocular pressure, infusion pressure, better than Infinity and better than in Centurion. It's 3 times faster. So the simple reason, the response time of a vacuum in a Venturi machine is better. Now, as sir, Dr. Reddy, with your permission, I just take 2 minutes extra to explain how the cavitronics works.
Yeah,
now,
go ahead.
In a Venturi machine, as I said, or in any phaco machine, the main cutting is caused by the cavitronics and the mechanical impact. Now, all machines will have the same mechanical impact, but a machine with a longer stroke length will have a better mechanical impact. So here again, a Stellaris wins because it is working at a 28.5 kilohertz frequency. Second, the cavitration. This is the mechanical impact. Now, this would be fixed for different machines. Stellaris is 72 kilometers speed. Acoustical wave, we will not talk. This is interesting. So when a cavitation, what happens in cavitation is when the phaco tip goes and hits the cataract and comes back, if it has a longer time to come back, the bubble size caused by the cavitronic is larger. And when this bubble implodes, it releases higher energy. So all machines which have a higher frequency will create smaller bubbles, but a machine which is got a lower frequency will create a larger bubble, hence a larger, more frequency and more energy released. Now, this is a frequency of most of the machines used in the market. As we say, Stellaris is a very low frequency machine. Now, to make us understand how the cavitronic works, sir, I will explain. This is a video of an AK-47 gun fired underwater. See what happens. The bullet has been fired. This is the first explosion, and now the implosion. See the bulb. This is the implosion. Now, this implosion releases 2.8 times higher energy than the explosion itself. Now, we will again see this. The gun is firing. This is in very slow motion. Implosion, and there you see release of energy. The similar thing is seen in a phaco tip, and we will see one more video. This is an interesting video. You will see that the gun is fired underwater, and now you notice there is far more energy released with the implosion of the cavitronics. So much so that the water even on the surface comes out. This is what causes the most cutting in a cataract machine more than a mechanical impact. An average surgeon understands maybe the phaco tip is cutting into the cataract, but that is only 25% of the cutting. 70% of the cutting is coming from the cavitronics. So which gives us to the very fact that the machine like Millennium working at 28 kilohertz has got far larger cavitronic bubbles, releases more energy, and is coupled with the microflow tip, gives you a very, very good cutting energy. Now this is again, I will jump. Yeah. Now again, this is again coming to the attune. This is how the attune mechanism works in this new machine. So you have adaptive fluidics, which are maintaining an inflow, constant infusion pressure, attune, which is collaborating your phaco energy delivery, using it to its maximum efficiency, maximum cutting, least heat generation with using in combination with the microflow, and a dual linear Bluetooth foot pedal, which actually enhances the experience of the surgery. Now, this is again not my part, but the retina part is that, you know, the new Vitis cutting system, which is there, which is giving you 1.7 million cuts per second. This is even, you know, it beats imagination that you could have a vitrectomy machine, which is working on an ultrasonic platform, and it cuts the vitreous at the edge of the cutting tip at 1.7 million cuts a second. I think that is going to take the vitrectomy and for posterior surgeons, posterior segment surgeons to the next generation. So no wonder they call the Stellaris Elite the machine for the next generation. So you have a cutting option, which is increased to 15,000. As I was talking about, this is the most intriguing thing. We are looking forward to having this in our systems now. And I'm told by Bausch & Lomb that probably they'll be coming in very soon. Now, this is going to transform the way vitreous surgery is done. Thank you. Thanks a lot.
Thanks, Kamal. That's a lovely presentation. And thank you, gentlemen and Madam Dr. Meenakshi, for a wonderful session. I'm sure, you know, I've been a great user of Bausch & Lomb. As you all know, I did the prototype work on the Victus and also the Teneo. And Victus, I just want to make one comment, if you may agree or may not agree, because in that period of time, I've done about 12 pediatric cases, because Victus machine is the only machine with the microscope attached to it. So I wouldn't say a sterile surgery, but a clean surgery can definitely be taken up in pediatric patients, and you get a beautiful capsulotomy in them. I have even tried a posterior capsulotomy and an anterior vitrectomy, and very successfully with the Victus. Victus is the only machine that can do that. And its energy also is so good. Your very hard cataracts are very friendly. You know, I've used multiple femoral laser machines now in my exhibition. So Victus, that is one thing. And the Teneo, I mean, I'm sure you have all experienced it, but I did do some PRKs, Supracar PRKs with excellent results. Any comments? Because we have a couple more minutes, I think.
Doesn't the epithelial healing hamper your Supracar results?
That is what I thought, Rishi, from a theoretical point of view. But practically speaking, when I did it, I got good results. So meaning it doesn't affect.
Great.
Yeah. Dr. Chowdhury?
Yeah, regarding the toric presentation, just a small point to add. If we are using the total corneal power either from the IL Master 700 or from the Pentacam as Holliday's EKR values, then we should not simultaneously use the Barrett's calculator.
Yes.
Then it should be we should use the classical toric calculator, because the Barrett calculator is designed to predict the posterior corneal astigmatism. Whereas in
Dr.
total corneal
Bhaskar,
astigmatism,
Barrett now also has a TK calculator for total corneal.
Yeah, but the classical Barrett calculator should not be used if you are using the TK values. And the SIA component, sorry, sir?
No, sorry, please go ahead.
Yeah, and the SIA values now that we are feeding in should be in the centroid form, not in the classical form. So most of us would be using 0.25 diopters in the classical form, which in the centroid form would come to 0.1.
Kamal, I'm like you, I'm a lover of these Venturi machines, the Stellaris, ever since it gave birth, you know, to the previous small models also. I've been with the Venturi from the beginning. Your presentation is so nice and even more educating for me.
Thank you, sir.
But can you say, with the chamber maintenance, can you make one comment? Anything that comes to your mind regarding chamber maintenance?
I am using Stellaris since 2005.
Oh, sorry,
and,
Dr.
Yeah.
And
I've done, I think, more than 50,000 cataract with the Stellaris.
Great.
And I am fully satisfied with the chamber stability and everything. It hardly takes 2.5 minutes to do the cataract surgery with the Stellaris.
Because I find once in a while, I mean, very rarely, I get that upthrust, and then I slow down, of course, and not a big deal, but like you, I've done a few cases and I'm so happy with it.
Sir, my simple submission would be that my love for this technology and machine goes that I bought 9 of these. We bought 9 more machines. And for all our friends.
Bosch & Lomb, you're the happiest customer for them.
And the best part is, sir, the combination of a microflow needle, I think it's made for a 28,000 kilohertz handpiece. And the way it couples with the machine is amazing. I've also, again, off the cuff, no commercial interest, I've started combining this Stellaris machine on very hard cases with an Earthly tip. This is off the label thing, and it is magic. So I can recommend to all my friends who have a black cataract, try using a Stellaris machine.
Yes,
with an Earthly tip. It is magic. Even Earthly can't imagine what their tip can do with Stellaris.
Rishi, do you have a Stellaris, Rishi?
Yes, sir, we have got 2.
But sir, we have
3. Yeah, we've got 3.
As we have to move on to our next session.
Yes, sure. Thank you very much.
Thank you, everyone.
Thanks,
wonderful
session.
Thank you, sir. Always a pleasure, sir. Always.
Thank you so much. It was been a great pleasure to have you all. Stay safe.
Thank you
so much.
Thank you.
Thank you. Bye-bye.